Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it.
Hi, and welcome to today's podcast as part of the Reducing Risk series that we have. We have been going through a mini-series, if you like, on consent. And today's topic is the confused patient and what do you do? I'm joined today by my colleagues, Dr. Lucy Gibbard and Dr. Tim Cookson, and I'm Sam King. So when we think about the confused patient, often it can be a little bit hairy, if you like. It can be a little bit anxiety-provoking for clinicians as to what to do. And this podcast is going to explore consent for the cognitively impaired patient. Now, this is a fictional case based on common scenarios that you might see in your everyday work. It is about a gastroenterologist, but I'm sure you can apply it to your specialty. So Mr. RB is a 66-year-old Māori male. His wife died in 2013 due to complications from a stroke. His wife's only son from a previous relationship lives in Brisbane and has not had any contact with RB for over 8 years. RB does have a niece in the far north with whom he has intermittent contact. RB was admitted in April 2022 with collapse and hemiparesis. The CT confirmed a subdural hemorrhage, and RB had surgery, made a moderate functional recovery, but was unsafe with swallowing and so was referred to rehab. He made minimal improvements in his swallow. He was still unable to swallow safely and was pulling at his nasogastric tube secondary to his confusion. RB was referred to the gastroenterologist for a gastrostomy insertion. Tim, let's just say that you are the gastroenterologist. What do you think you would need to consider in this patient with regards to consent?
Well, I've always wanted to be a gastroenterologist. I think it'd be quite fun. But in the absence of actually being one, the first obvious thing is you need to make a clear decision about competence. It looks from the face of it that he's quite confused, and that decision may be quite easy to make. But it does need to be formally assessed and recorded that he is in this case, no longer competent to make those decisions about his own health and welfare. If that's the case, then you need to then think, well, is there someone else who can make that decision for him? And of course, in New Zealand, that would be the enduring power of attorney, or possibly a welfare guardian, but more likely an enduring power of attorney. So you'd want to try and get hold of that person if they exist, and they can then, once Mr. RB has been confirmed as no longer having competence to make that decision, the EPOA can be enacted and the attorney, the EPOA, can then make those decisions on behalf of the patient. And they always need to act in the best interest of the patient, who's also called the donor in this case. Now, it's important to clarify that a next of kin is not an EPOA, so they're not an attorney, and they don't have any legal rights to make decisions on behalf of their next of kin. They can be useful if there is no one who can give consent, so there's no attorney. They can be useful to help guide the clinicians as to what the patient might have wanted themselves, because they may know the patient well, have a clear understanding of what their preferences were in life and illness, and can provide a guide from that perspective.
I think the next of kin is quite a common misconception as being a legal guardian in New Zealand, I think. And it's often actually in the actual relatives think, this is my spouse. He's not able to make a decision, therefore I can make that decision for him. So it's often not just the clinicians that think it might be that way, but often the patients or their families often believe that there is some legal standing to being the next of kin. So I think it's a common thing we get on our advice line is people ringing up and saying, oh, the next of kin says X, Y, and Z, and having to explain that actually the next of kin doesn't have any right to say anything, but they can give information, like you say, it's useful.
And then that's the same for when they're asking for health information, isn't it? The next of kin often feel they have a right to that, but clearly they don't, because they've got no legal standing. I do digress a little bit. Sorry about that. I thought it might be useful to go through the test of capacity because it is set out in law, particularly in the UK, but I think it's recently been written into the End of Life Choice Act in New Zealand. And I wonder, Lucy, would you mind just going through that for us?
Yeah, well, there are several things that you need to look at when you're going through a competency or a capacity assessment. And the first is you need to decide whether the patient can understand the nature and purpose of the particular decision and appreciates its significance for them. So the important thing there is actually you've got to be talking about a particular decision. So you need to know what decision you're asking the patient to make, and then can they understand it. You also need to check that they can retain the information for the time needed to make that decision. So they've got to be able to understand the information and retain the information. They also need to be able to use it to weigh up relevant information as part of the reasoning process. They need to be able to look at the pros and cons and weigh up what the possible consequences might be and what that might mean for them. And then the final thing is they need to be able to communicate their decision, either verbally or in writing or by some other means. And that doesn't have to be that they can speak. So somebody can still have capacity to make their own decisions, even if they can't speak, if they have some other way of communicating. And part of when you're doing a competency assessment, it's really important that you can give the patient the aids or the things they need to be able to have capacity if you can. So if they needed an interpreter or someone who can do sign language, you need to give them the opportunity to be as competent as they can be. And it's useful, as I said, to remember that the ability to make a decision is about a particular matter at the time. So that if we're talking about can they make a decision to have surgery or can they make a decision where they want to live, those are big decisions and you need quite a high level of capacity to do them. For smaller decisions, the patient may have capacity to allow a cast to be put on or something like that. We also need to remember that we presume that everyone's got capacity unless there's evidence otherwise. So there is a presumption of capacity. And that it's not an on-off thing. I think often people think that the patient it has no capacity at the moment, and that means they won't have capacity in the future. And I think clearly that's not the case. We often see patients admitted to hospital with a UTI or something. They're lacking capacity. Somebody activates their EPOA because they say, oh, this person hasn't got capacity. But then a week later, their UTI has been treated and they've got capacity back again. But that EPOA thinks that they now have the ability to make decisions for that person, which they don't. So I think, is there anything else that you would have covered in that, Sam?
No, I think that's really comprehensive. Thanks, Lucy. So what I've picked up is it's decision specific and time specific. I mean, I have to say some people before they had their coffee in the morning probably aren't that competent. So, I think it fluctuates during the day.
Speaking for yourself.
No, I remain silent on that point. Thank you, Tim.
The bits that I've got from that are twofold. Is that, this business of being able to make a decision about one thing but not another. So it's not an all-encompassing thing. It's a very specific to what the particular issue is. And then that other thing about it's not a permanent decision either. And I've certainly had experience with that in practice of people who lacked competence for quite some time, but over time recovered sufficiently to then gain a degree of competency so that it changed how you interacted with them.
I think autonomy is hugely important in society, and so people or patients should be allowed to make decisions to the limit of their capacity. And often that's time consuming, and so it's easier to have a substitute decision maker. But the reality is that I think every patient deserves to have to use their autonomy to the highest degree that they can.
And that's actually really clear in the Act relating to enduring power of attorney, that the attorney is obliged to communicate in detail with the donor or the patient, and also to try and facilitate as much as possible their ability to make decisions.
Their own decision. Yeah, exactly.
That's good. Often when people are refusing treatment, we often think that they lack competence. What do you think about that, Tim?
Well, no, they may lack competence, but you can't assume that. And patients have certainly got the rights to refuse treatment. There's no question about that. And even when their decisions seem to be totally crazy, they've still got the rights to make those decisions. The crazier, I guess, the decision is, the more we need to confirm that they are in fact competent to make that decision. But they certainly are. And there was a case example of this, and this has been published, so we can reveal the name, Mr. All Means All, who was a guest of one of our institutions, which he was unable to leave, and he was sentenced to 4 months imprisonment on 6 counts of threatening to kill. He, very soon after going into prison, began a hunger strike and refused to eat or drink anything because he believed that a detective had lied in giving evidence at his trial, and he thought that by going on a hunger strike he would encourage the truth to finally surface via the hunger strike. So this was a bit problematic for both the prison and for the hospital that was involved, and so they went to court to get a declaration to clarify their legal obligation towards his treatment, or in this case, his non-treatment. And the judge, because Mr. All Means All was a bit unclear in being able to instruct a lawyer, had a counsel to assist him. And the first thing that they did was, of course, to make a decision as to whether he had a psychiatric condition which would render him to be not competent to make that decision. This was done, and he was judged to not have a mental impairment or condition. So then corrections wanted one of 2 things. One was either that they could give him treatment by way of artificial hydration and nutrition when his life got to the stage where it was in peril, or whether when he was no longer able to indicate whether or not he consented to treatment, because starvation can certainly have an impact on one's ability to cognate effectively. But they also sought an alternative ruling, which that they had a lawful excuse for not providing medical treatment, and that so long as he continued to refuse consent. And this was an important kind of combination of things. So one was, can we force this man to have treatment? And then the second was, well, if we can't force him, are we absolved from not forcing him to have treatment? And it's not just corrections that have been faced with this kind of scenario. And so the court decided that an adult patient, sound of mind, is entitled to refuse or undergo treatment for whatever reason, even if the result of doing so means that they will die. And it was felt, and reference was made to a House of Lords decision, that the principle of the sanctity of human life was not as strong as the principle of self-determination. So you can make a determination yourself that you will take means that would end in your no longer being alive, and that no one could force you or force treatment upon you just to keep you alive. Have I got that right on the explanation? Right. And it was important to say that this was not akin to suicide, because death actually wasn't his intended result. He wanted to stay alive, but he wanted his hunger strike to achieve the aim of getting the detective to say that he had lied and giving evidence at his trial. So the judge considered a joint declaration and released it, and that he said that persons owing a duty of care to Mr. All Means All will have a lawful excuse for not providing medical treatment to him while he continues not to give informed consent to such treatment, or an advance directive refusing consent is in place.
It's a very interesting case, isn't it? That the psychiatrist deemed that Mr. All Means All was competent to make that decision, and therefore they couldn't force feed him or hydrate him. And I think most clinicians in these situations would want to go to the lengths of a court order. I don't know. it's too risky otherwise, isn't it?
And I think that other thing is that often you think when someone's made a foolish decision, well, they must be incompetent, that you work backwards from the bad decision to the competency. Whereas in fact, a competent person can make a very foolish decision and they're still allowed to make it. So you can't assume incompetence just because the decision is one that you can't understand or that seems completely crazy. It doesn't actually mean that it's an incompetent decision.
Mm-hmm.
I think too that it's important that if there is doubt or you're feeling, as a clinician, you're feeling at risk, that you do obtain a psychiatrist opinion. And occasionally I know that I've recommended that they have 2 psychiatrists give an opinion on the same patient so that everybody is on the same page before they proceed.
I've actually got a very similar case at the moment of a very elderly woman who's decided that actually she's had a very long innings, she doesn't want to live anymore, and she's just going to stop eating and drinking. And has told her doctor, which of course puts him in a major dilemma as to what he needs to do, what are his responsibilities. And so we've been going through much of the same issues that we've talked about in that case in terms of establishing issue of sound mind. And if he doesn't provide treatment or insist to the limits of his ability, because of course as GPs we can't insist that people have treatment, that he's not going to be then vulnerable for not insisting that she takes nutrition, etc.
And it's a slightly different situation because actually her intended consequence is not to get a detective to change his mind.
No. She's got another aim in mind.
Yep.
Interesting case. So let's go back to the original story with Mr. RB. The gastroenterologist is having to think about, can he proceed? What does he have to do with regards to consent for this particular patient? But the patient did have surgery earlier for the subdural hemorrhage. Lucy, is the situation with treating the subdural hemorrhage versus
putting in the gases? Is it different?
In what way is it different?
Yeah, it is different. I think that doctrine of necessity is often used as the reason for emergency treatment in an emergency situation where someone lacks competence. And that basically means that actually it was necessary and there was no other alternative in order to save life. And so when he's got a subdural and he's incompetent because of his subdural and he needs an urgent burr hole or some treatment, in that situation you're using the doctrine of necessity saying, well, he can't consent, we haven't got anyone else who can consent, and it's life-saving, therefore we have to proceed. And that's basically what the doctrine of necessity says. So that's different from putting in a gastrostomy where actually although in the long run it may be life-saving, actually there isn't such an acute need, and so using the doctrine of necessity is a little less secure.
And in this case, of course, he does have a nasogastric tube, so he is getting the nutrition that he requires, but the problem is because of his confusion, he's pulling it out. So the gastrostomy is almost more for the medical staff or the people who are caring for him rather than for him personally.
To make his cares easier, isn't it? Yeah.
Yeah, and then the good thing is that it has been accepted in common law in New Zealand, the doctrine of necessity. I mean, I know it's common in the UK and it's accepted there, but it is also accepted in New Zealand jurisdiction. So this patient was assessed as lacking competence, and you talked earlier, Tim, about you would ask whether there's an EPOA or welfare guardian, and in this case there isn't. So who can actually provide lawful consent in this situation?
Well, the first thing to consider is that there's no time critical aspect to this case, so they don't have to make this decision rapidly. So the only legal route there is, if there's no EPOA or welfare guardian, is for the court to make this decision. And this may take time, and it may take there may be some costs involved, but it would be something certainly that the DHB would want to pursue. Because the risks of proceeding without any consent, where there's no time critical nature, would be significant. And certainly if there's a complication, then the niece could lodge a complaint, and it would be there'd certainly be grounds for it. So under Right 7.4 of the Code of Patient Rights, which we talked a wee bit about already, you can treat if it's in the best interests of the consumer and reasonable steps have been taken to ascertain the views of the consumer, and the treatment is consistent with those views if it's known, or then it might be a next of kin or someone close to the patient who knew the views of the patient. But in this scenario, that's unlikely. This is an unusual situation where a gastrostomy is going to be needed. And so you can't get the views of the consumer. And it's very unlikely that he would have had lengthy discussions with his friends about whether he was going to have a tube in his stomach or not. So you can't really get the views of those close to the patient. So I would have said that in this situation, clinicians can't proceed under Right 7.4 of the code.
I don't know about that, Tim. Actually, I kind of think that they can. I think we can agree it's probably in his best interests to have a gastrostomy, and that most reasonable people in that situation probably would agree to it. And I think all you've got to do is make reasonable steps to ascertain the views of the consumer. So actually, I think that you could argue under Right 7.4 that you could provide that treatment, especially if you showed that you've been through that process and tried to ascertain the views of the consumer. I think you could. I think it's safer to go to court and get a pleasant order, but actually, yeah, I think there are situations where you could argue that that you've done enough to cover off Right 7.4. What do you think, Sam?
Yeah, I would probably tend to agree with you, Lucy. I think that there are huge numbers of patients being treated under Right 7.4 who probably should have a welfare guardian appointed but haven't. And I think in this situation, it would be reasonable to do this. I think for court cases, it generally would be for, I would have thought, high intervention. For example, the Mr. All Meets All case. And I don't know that DHBs or hospitals are particularly keen on applying to the court, except under extreme urgency or dire need. So anyway, in this particular case, the physicians agree that gastrostomy is in the patient's best interest and proceed with the insertion. And after they do that, the patient's niece makes contact. She is unhappy that this is proceeded without discussing this with her first. The patient's first wife had died following complications of a gastrostomy insertion, and that's why the niece is very unhappy. So do you think the clinicians are vulnerable here?
Well, that comes back to my comment.
Okay.
And the critical bit for me here is that there actually was no urgency. And actually, I'm not an expert in tubes, but where there is an alternative which is possible, then I think you have to be really careful about doing a procedure which has got significant risks associated with it. And unless it was really clear that the risks of the nasogastric tube and having been reinserted on numerous occasions was greater than the risks associated with the gastrotomy, then the clinicians are going to be on.
It's so hard, isn't it? Because actually, it's how hard did they try and find the niece is probably part of the issue, isn't it? Because if they'd actually tried to ascertain the views of the consumer, they'd asked the next door neighbour and everyone else who they could find that knew him what he would want. I think they have fulfilled the Right 7.4, but if they hadn't tried, if they just said, "Oh no, we think it's in its best interests, off we go," I think that's different. But I think if they've tried to fulfil the criteria of Right 7.4, I think they're probably all right. And at the end of the day, the niece has no legal standing to tell them not to do it.
No.
She can't say, "No, you're not allowed to put a gastrostomy tube," and she's not the EPOA.
I guess if there was time and the niece had appeared perhaps a little earlier, they could have gone to the lengths of using the appointing a welfare guardian, and then she could step into his shoes and make those decisions for him. But I think that I would say you could go either way. So I'm splitting the difference between you and Tim.
You're sitting on the fence there, Sam.
I am. I'm sitting on the fence. And you could appoint a welfare guardian, or you could treat under Right 7.4. And to be honest, if they treated under Right 7.4, I don't think they would be in difficulty. if this had gone to the HDC. But I guess until a specific case like this goes to the HDC, we won't know the outcome of it.
And a lot might hinge on just how clear you can be about it being in the patient's best interests. Because if it's a slightly debatable one, then that's going to be a lot less clear than where it's quite clear there's strong evidence that, yes, putting in a gastrostomy tube has been shown to be much safer, etc., etc.
If you'd had multiple aspiration pneumonia, episodes, then I suppose you'd say, it's far safer for the patient. But I guess without that, it's difficult to know where the HDC would come down on this. And I think it would really come down to the nitty-gritty details of the case, which I haven't provided for you. So I'm very sorry about that. So in this fictitious case, let's just say the niece recalls that Mr. RB had indicated he wouldn't want to be kept alive by tubes and pumps if he was ever in a similar situation to his wife. And he would tell this to his niece all the time. So if you were the clinician, Lucy, would you consider this to be an advance directive?
Yeah, it's always hard, isn't it, when the niece just says, because you don't know the circumstances under which he said it or exactly what he meant by it. It's one person reporting it who may have views of her own. So, and I think advance directives, obviously, every consumer can use an advance directive in accordance with common law, and the advance directive basically can then be used as evidence of the person's wishes, like a consent. But the problem is that advance directive, you've got to be very sure that the patient had anticipated the situation that they're now in, and was at that time in advance able to weigh up the pros and cons and everything else of the situation. And that's actually very hard to show. And I think even if he told his niece, "Oh, I wouldn't want to have pipes and tubes keeping me alive," which, may well have been his view, that doesn't mean necessarily if he had competence now that he would refuse a gastrostomy. It's hard to know, isn't it? And so I think that I personally would not consider it an advance directive, because I wouldn't have enough evidence really that he actually understood the consequences of not having it now, or of the situation he was in now.
So what I'm hearing is it's better to err on the side of caution, to say that it wasn't an advance directive. And in order to be valid, an advance directive, it can be written or it can actually be verbal, surprisingly. The question would be, was the patient, did he have capacity at the time when they made the advance directive? What information did the person receive when they made the advance directive? Because obviously patients don't have any idea what that means when they say, I don't want any life-saving treatment. How reliable is the witness? How reliable is this niece? You don't know whether there was any degree of coercion, whether she, may or may not be has any financial gain in the decision. When was the advance directive made? Was it made 10 years ago, or was it made last week? And there's a huge difference, and particularly when you think about the Jehovah's Witness cases where people are refusing blood products, you really do want to know that they continue to follow that particular decision. And as Lucy mentioned, was it clear and specific? And was an EPOA created after the advance directive? Because the EPOA then steps into the shoes of the patient and can negate the advance directive made by the patient.
Can they?
They can.
Interesting.
If it was after.
Tim, when are advance directives not valid?
Well, you can't have an advance directive saying that you want euthanasia or assisted dying. You can't have an advance directive that says, I want to have every single treatment under the sun, no matter how futile it might be, if I get admitted to hospital. So you can't force clinicians to do interventions which would be inappropriate. If the advance directive was actually withdrawn while the patient still had capacity, then of course it's no longer valid. So if they've had it tattooed on their chest, that's going to be challenging for them. And then, as we've discussed, if an EPOA is appointed after the advance directive, then the attorney then has the rights to negate that advance directive. And if there's clear evidence that actually the patient, having made an advance directive, has then taken steps that contradict the advance directive. So has said, I never want to have a drip ever inserted into my arm again, but when he needed pain relief for his broken leg, he was quite happy to have a drip inserted into his arm to get rapid pain relief. So those would be the kind of things that would negate an advance directive.
So if you're unsure if an advance directive is valid or not, there was Lord Donaldson in a case in the UK has said, in case of doubt, that doubt falls to be resolved in favour of preservation of life. And that's what you can take away about advance directives, that if there is doubt, we preserve life, and then you can argue about it later if you like. But no, I don't think any court's going to criticise a doctor for saving life when there is doubt about that advance directive. Thanks, Tim and Lucy. Just in terms of the learning points from today, hopefully you will have taken from this episode that you need to ascertain if the patient is competent to provide consent. Lawful consent can only be given by the competent patient, the court, a welfare guardian or EPOA holder where the patient is not competent, and the next of kin cannot provide lawful consent. If no one can consent and there is urgency, the doctrine of necessity does apply in New Zealand in common law. And a valid advance directive is legally binding. The issue is always going to be whether the advance directive is in fact valid. And if you have doubt, please do seek advice from your hospital lawyer or your indemnifier. That's our episode for today. Thank you, Tim, and thank you, Lucy, for your pearls of wisdom and the fact that you sat on opposite sides of the fence. I actually think it's really interesting to debate these issues, and often with medico-legal issues, it's very hard to know exactly where to land this, because unless something goes through court or through the HDC, we don't actually know. Just shows how tricky things can be. So thank you for listening to our podcast today, and we hope to catch you on the next one. If you do have any comments or questions that you have, you can email us on nzpodcasts@medicalprotection.org, or if you're a member, you can call our advice line on 0800 2255 677.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.